Schizophrenia is probably the most serious mental disease that we deal with. It affects about 1% of the population, and that's pretty much true worldwide. It's a disease that tends to occur in late adolescence or early adulthood, and is usually chronic, sometimes with remissions and exacerbations, but it's a disease that usually affects people for their entire lives. I think the costs to society of schizophrenia are enormous. I mean, first you've got the costs in terms of lost productivity. Then you've got the costs in terms of direct care. And then in addition, psychosocial services, even lost productivity on the part of family members who end up having to take time off from work to help, care for the person. We frequently don't recognize sufficiently the fact that suicide is an enormous risk in schizophrenia, that anywhere between 5 and 10% of patients with this disease ultimately kill themselves. So it's a disease with a tremendous amount of morbidity and mortality, and the health care expense associated with that is actually quite staggering. In the U.S., for example, the cost of health care in general is running now about 12% of the gross national product. And the estimates are that the treatment of mental illness accounts for about 10% of that. And schizophrenia certainly is really the major mental illness in terms of its cost.
But what exactly is this illness we call schizophrenia? Contrary to popular belief, schizophrenia is not a split personality disorder in the sense of Dr. Jekyll and Mr. Hyde.
There is, in a sense, a splitting of the patient from reality. Their thoughts become preoccupied with other things, often bizarre, strange ideas, hallucinations that can be tormenting and worrying. And there's also a separation of the patient's mind from their own really thoughts and feelings, and the patient becomes more and more preoccupied with these kinds of experiences, and often then becomes sort of set apart from their family and the rest of society, and more seclusive, and can end up very isolated. The onset of the illness is usually late teens, early 20s, particularly in males, perhaps a few years later in females. The start may be what's termed an insidious onset, slow, gradual onset. It may be typically a failure to fulfill their sort of academic promise.
It may be difficult to make the diagnosis at first, because often the only features are a lack of drive and social withdrawal. But in time, most patients will experience a psychotic episode, when the characteristic psychotic or positive symptoms occur. One form of positive symptom is a delusion.
The standard definition of a delusion is a sort of false, unshakable belief, which is inappropriate for the social and religious background, which is okay as far as it goes. I think, though, the essence of a delusion is that there is usually a symbolic misinterpretation of a normal perception, something that happens, or of a thought. And that misinterpretation comes complete with its own sense of conviction.
This patient believes that his body has been invaded by an object he calls a Sputnik. Delusions may persist even when a patient is not acutely ill.
You told me before about a Sputnik. Can you tell me about that? How does it get into your body?
Through my eye, only, I don't know, I think through my eye, because I don't see it, I don't feel nowhere else. I feel only it coming from my eye.
And when it gets inside your body, what does it do?
It doesn't do nothing for about half an hour. Then it's everywhere. It's in me back, on me thingy, my skin going like that. If you see it, if I show you like that, you will see something coming up, because I watch it myself. I went through the mirror, and I look, or here, or in my leg, everywhere.
Do you think that these experiences of the Sputnik could be part of an illness?
Impossible, Dr. Banks. This is impossible. I believe in illness because I was ill. I'm fit, no. but I don't believe that this is a part of my illness.
Patients are also bombarded by hallucinations during the acute phase of the illness.
They offer me even.
An hallucination is a sensory experience in the absence of an external stimulus.
That's good, man.
Patients often report hearing voices when there's no one there.
When did you first become ill?
It was 4th April 1969. I went to Preston Hospital in Liverpool.
And what were the problems at the time?
Well, problems I got, you know, somebody been talking to my back of my head, voices. I heard voices, you know. The voices was bothering me a lot.
What did the voices say to you?
Well, in the beginning, when they start talking to me, they tell me all sorts of things. I was talking to the moon. They told me to talk to the moon. I was talking to the moon. When I was sometime walking or coming from work, they said, go to a bar, buy me beer. The moon tell me, buy me beer. All right, I buy beer. Then I talk to the beer. Then the barman throw me out.
The feeling of passivity is common in schizophrenia. The voices seem to control the patient's thoughts and actions. The voices may also be frightening.
Can you tell me about the voices?
Yes, the voices would say, sometimes they would say frightening things. They would say, oh, I'm a devil, I'm going to destroy you. That's what they would say.
The third type of positive symptom is termed thought disorder. Patients may make up new words, neologisms, or may use words in an idiosyncratic way.
You said you'd taken stick from people for a number of years. What did you mean by that?
I took stick within myself, you know, I mean, this is the protraction, you know what I mean? And it was...
The protraction?
Yeah, these are words, yeah, I don't know. Yeah, what can I say? Maybe I'm hearing, this is another stage, I don't know, that's what I'm hearing.
Can you just tell me what the word protraction means?
Well, I don't know.
The logical pattern of thought may be disturbed. The patient may start off answering a question rationally, but then it drifts into something else and never gets back to the original topic.
You said copying your thoughts.
Yeah, I really felt that, you know?
Can you just explain what copying your thoughts is?
Well, it's just, I mean, my thought and their mouth is saying the same thing. You know, I think I imagine it. It's the fact that I think people are trying to help me in Pimlico, you know, and it's really hard to explain, it really is.
How would they be trying to help you?
Well, if they could copy my thought, then I could analyse it from there, if you know what I mean. Do you understand what I mean?
I'm not sure, no. Can you explain a bit more?
Well, I can't say these things, but they're only going to change it anyway. They'll just change it.
Who will change it?
The Conservative government.
The positive symptoms which characterize the acute phase of the illness are very disturbing for the patient. But it's the so-called negative symptoms which may be more difficult for family and friends to deal with.
The negative symptoms, I think, can, for many patients, constitute the most sort of socially disabling, most persistent and the most sort of treatment-resistant elements of their condition. But perhaps the key thing is this lack of volition, this lack of drive to do things. And that leads also to a social withdrawal and an isolation, and clearly is going to impact upon rehabilitation efforts and impact upon their ability really to cope.
The third group of symptoms are the emotional or affective symptoms. Affect may be disturbed in schizophrenia in a number of ways. Depression is a common problem and is a serious affective symptom. Suicide is not uncommon, and those with depression may be more at risk. So schizophrenia may lead to a wide variety of symptoms. But how is it diagnosed?
Diagnosis is really still at the descriptive level. I mean, we have no blood test or no X-ray that will give us the answer. So it's still really to the level of describing the sorts of symptoms and phenomena we've been talking about and seeing if they're present as a syndrome.
Two major classification systems have been developed to help psychiatrists make accurate diagnoses. These are ICD-10 and DSM-3R. DSM-3R is probably the most widely used. According to this system, a patient must satisfy 6 criteria before the diagnosis is made. Many avenues of research are being pursued worldwide in the search for a better understanding of schizophrenia.
What the CT scans, MRI scans and post-mortem examinations have revealed is that there are structural abnormalities in the brains of some people with schizophrenia. One of the questions, if you find an abnormality like that, is it the result of a degenerative process, or is it the result of a neurodevelopmental process? And the fact that the structural abnormalities we find are not progressive, and that they seem to be there early in the disease, that and other evidence suggests that it may be a neurodevelopmental process we're dealing with.
But what is going on at the neurotransmitter level? For many years, the neurotransmitter dopamine has been closely linked with theories about the disease. Dopaminergic neurons are widely distributed in the brain. Overactivity in this dopaminergic system is believed to be responsible for many of the symptoms of schizophrenia. Conventional neuroleptics are the mainstay of management. These are used in the acute phase to reduce the cognitive, perceptual, and emotional disturbances.
If we continue the medication on a long-term basis, we can also very often prevent subsequent psychotic episodes, relapse, rehospitalization, and so forth. So those treatments have made it much easier for us to manage the disease. It's made it much more possible for us to bring to bear a variety of other treatments, psychotherapies, family therapies, psychosocial treatment, vocational rehabilitation, and so forth. So, you know, I think there's a whole array of things that we need to do to improve outcome in this disease, but the use of these medications has been absolutely critical.
So, neuroleptic drugs play a key role in treatment. Most conventional neuroleptics, like haloperidol, are antagonists of dopamine neurotransmission at dopamine D2 receptors. It is this dopaminergic blockade which is believed to account for the reduction in positive symptoms seen with these agents. The precise mechanism by which they do this is not known, but it is believed that blockade of neurotransmission in the mesolimbic pathway is important. But D2 receptors are also present elsewhere, including in the nigrostriatal pathway. Blockade at this site is believed to be responsible for some very serious movement disorders, the so-called extrapyramidal side effects.
The motor side effects are particularly important because they're relatively common. They can be disabling and distressing. They can cause patients, as with the other side effects, to be reluctant to take their medication because they want to avoid these problems. And they can also confound our clinical assessment of patients. For example, acutely one sees Parkinsonism, which is so-called because it resembles Parkinson's disease, and is characterized by tremor and rigidity. There is akathisia, which literally means not to sit, and that's a mixture of a subjective sense of restlessness, an inability to sit still for any length of time, and characteristic motor disturbance of rocking from foot to foot when standing. And then there's the dystonias, acute dystonias, which is a disturbance of muscle tone, in a sense a muscle spasm, almost like cramp, can be very painful and tends to affect the eyes. Blepharospasm of forced eye closure can affect the jaw and the lips and the tongue, and often as well the neck being pulled to the side or pulled back in a distressing way, and the trunk and limbs can also be involved.
With conventional neuroleptics, other side effects can also occur due to the blockade of other neurotransmitter systems. Cholinergic blockade may lead to glaucoma, dry mouth, and constipation. Adrenergic blockade may cause cardiovascular effects and loss of libido. This patient has a very worrying long-term complication. It's called tardive dyskinesia and occurs in around 20% of patients. In most patients it's mild, but it may interfere with speech, and the bizarre movements may be a stigma in that they may make the patient look odd in the eyes of other people. It has been reported that the occurrence of acute extrapyramidal symptoms may predict the later development of tardive dyskinesia. Current therapy has some very significant and troublesome side effects. It also has little effect on the negative symptoms of schizophrenia. The search for new drugs which might overcome the drawbacks of conventional neuroleptics has focused on the investigation of other neurotransmitter systems. Investigation of the serotonin, or 5-HT system, has led to a new approach. It was scientists at the Janssen Research Foundation in Belgium who discovered ritanserin, the first specific central serotonin 5-HT2 receptor antagonist. Heading the team was Dr. Paul Janssen, founder of Janssen Pharmaceutica.
The first striking observation with serotonin antagonists was made in our sleep lab in England with ritanserin.
The serotonin antagonist was found to increase deep sleep in both normal volunteers and in patients with schizophrenia. But its effect in these patients went far beyond an improvement in sleep.
It was discovered empirically that the same drug actually had a striking effect on the negative symptoms of many of these patients. So the co-administration of a specific dopamine D2 receptor antagonist like haloperidol with a specific S2 serotonin antagonist like ritanserin resulted in a rather dramatic improvement of many patients with positive and negative symptoms that could not be helped with one drug or the other.
So the addition of the 5-HT2 antagonist ritanserin to the conventional neuroleptic haloperidol overcame one of the major drawbacks of conventional therapy. The task of the research chemists at Janssen was now clear: to design one drug which was both a dopamine D2 antagonist and a serotonin 5-HT2 antagonist. In 1984, their intensive research efforts were rewarded by the discovery of this molecule, risperidone, or Risperdal.
Few physicians and authorities, between brackets, like the idea of giving two drugs. They would rather have two properties combined in one drug. And risperidone actually is nothing else than one molecule that combines the properties of haloperidol and of ritanserin in a certain sense. So it's officially a combined D2 S2 receptor antagonist. That's the official explanation. But of course, it's more complicated than that.